Welcome to the deep dive. Today we are taking a closer look at one of the body's most persistent and, frankly, damaging processes, chronic inflammation. Our mission here is to really navigate the complexity, zeroing in on the actual cells involved and the chemical signals, the mediators that keep this whole thing going.
Yeah, it's such a critical topic. When people think inflammation, they usually picture something quick, like a cut or a sprain. That's acute inflammation, usually fast, hot, painful, but it resolves.
Right.
Chronic inflammation, or CI, it's the long game. It's defined by lasting weeks, months, sometimes years. And it's fundamentally different in its nature.
Different how? You mentioned it's not just one thing happening.
Exactly. Acute inflammation is mostly about getting rid of the threat quickly. But in CI, you've got this constant juggle. You have the ongoing inflammation, sure, but at the same time, you have continuous tissue injury happening and the body's simultaneous attempts at repair.
Wow, okay. So all three are sort of wrestling with each other.
That's a great way to put it. They coexist. They interfere with each other. And that's what creates this really complex, dynamic, and often destructive situation.
And does it always start with some big, obvious injury? Like, could you have this simmering away without even knowing?
Absolutely. I mean, CI can definitely follow an acute episode that just never got properly resolved. Maybe the bug wasn't cleared, But quite often it just starts quietly, insidiously, like a low-grade smoldering fire that maybe never had a big flare-up, you'd notice. The body just gets stuck in this fight mode it can't switch off.
Which is why it's so important, right? Because this underlies a huge range of really serious medical conditions.
Oh, absolutely staggering. We're talking about the foundation for so many major diseases. Think about conditions where the immune system is essentially attacking the body, the hypersensitivity diseases.
Like autoimmune problems.
Exactly. Rheumatoid arthritis, for instance. That's chronic inflammation, chewing away at the joints, causing pain, destruction, deformity. Or multiple sclerosis, where the target is the nervous system. But it's not just about the immune system attacking itself. Sometimes it's driven by things that aren't even alive.
Like environmental triggers.
Right. Consider silicosis, a lung disease. It comes from breathing in tiny silica particles, like from mining or sandblasting. These particles aren't alive, the body can't break them down, so it just keeps trying to wall them off, leading to persistent inflammation and scarring in the lungs.
Okay.
Or look inside our arteries, atherosclerosis, hardening of the arteries. That's driven by the buildup of cholesterol and lipids. The body sees these deposits as foreign or dangerous and mounts a chronic inflammatory response right there in the vessel wall, which over decades narrows the artery.
So it seems like the key word is persistent. What are the main ways this persistence happens? What keeps the fire lit?
Broadly, we can think of three main pathways. First, persistent infections. These are microbes the body finds really, really tough to eliminate.
Like what kind of microbe?
The classic example is Mycobacterium tuberculosis,
Yeah.
the bug that causes TB. It has this waxy coat that makes it super resistant to being killed by our immune cells. So the body fights it for years, often leading to a specific type of reaction called delayed type hypersensitivity.
And that prolonged fight often leads to those specific structures, the granulomas, right? We need to get into those.
We definitely do. The second pathway is those hypersensitivity diseases we touched on. This is where the immune system is just inappropriately activated. It's excessive, it attacks the wrong target, and it keeps itself going.
And that breaks down into attacking self versus attacking something harmless from outside.
Correct. So you have autoimmunity on one side attacking your own tissues. Hashimoto's thyroiditis is a good example, destroying the thyroid gland. On the other side, you have exaggerated reactions to harmless things in the environment, like pollen or dust mites, leading to allergic diseases. Bronchial asthma is a prime example of chronic allergic inflammation in the airways. These reactions don't serve a protective purpose, they just cause damage.
Okay, and the third cause, you mentioned silica, an external thing.
Right. The third is prolonged exposure to toxic agents. Silica is a great example of an exogenous or external agent. But we also have endogenous agents, things produced inside the body.
Like the cholesterol in atherosclerosis.
Exactly. The body perceives those lipid crystals almost like tiny foreign bodies, setting off this decades-long, low-level inflammatory process in the artery walls because it just can't clear them effectively.
So if a pathologist looks at a tissue sample, what are the dead giveaways that they're looking at? Chronic, not acute inflammation. What's the visual difference?
Oh, it's night and day under the microscope. Acute inflammation is all about, leaky blood vessels, lots of fluid, swelling, edema, and heaps of those first responder cells and neutrophils.
Okay.
Chronic inflammation looks very different. It tells a longer, more complex story.
Let's unpack the key visual signs. What are the hallmarks?
Okay, three main things. First, The type of cells changes. Instead of neutrophils dominating, you see an infiltration mainly of mononuclear cells.
Yeah.
We're talking macrophages, lymphocytes, and plasma cells.
A long-haul fighters, not the sprinters.
Precisely. Second, you see clear evidence of ongoing tissue destruction. This damage can be caused by the persistent bug or toxin itself, or, and this is really key, by the chemicals and enzymes released by the inflammatory cells trying to eliminate the problem. Collateral damage, essentially.
Right, friendly fire. Okay, and the third hallmark sounds almost paradoxical, the attempts at healing.
Yes. This is where so much of the long-term organ damage comes from. The body is constantly trying to replace the damaged tissue. It does this through fibrosis, which is laying down connective tissue, basically, scarring. And angiogenesis, growing new, often leaky small blood vessels.
So the body's effort to patch things up actually makes things worse in the long run.
In many chronic diseases, yes. The scar tissue, the fibrosis, isn't functional tissue. It distorts the organ's architecture, it stiffens it, it impairs its function. Think of liver cirrhosis or pulmonary fibrosis. That's the devastating end result of repair mechanisms gone into overdrive in a chronically inflamed environment.
So it's not just damage, it's damage and faulty repair happening constantly side by side.
Exactly. That dynamic interplay is what defines chronic inflammation.
Okay, let's zoom in on those cells. You said the key players are the mononuclear cells. Let's start with the big one, the central figure, the macrophage.
Right. Macrophages are usually the dominant cell type you see in chronic inflammation sites. They're part of this network called the mononuclear phagocyte system. They're fascinating cells.
Where do they come from?
Well, many originate from precursors in the bone marrow. These circulate in the blood for maybe a day or so with monocytes. Then they migrate out into the tissues, and that's where they transform into activated macrophages, ready for action.
But wait, aren't there macrophages already living in our tissues?
Yes, good point. That's the other source. Some macrophage populations are actually derived from embryonic precursors. They take up residence in specific tissues very early on and stay there for life. These are the resident macrophages.
Like guards posted at specific locations.
Exactly. Like Kupffer cells lining the sinusoids in the liver, microglia watching over the brain and spinal cord, or alveolar macrophages patrolling the air sacs in the lungs. They're specialized for their location, but they share core macrophage functions when activated.
And once they are activated, what's in their toolkit? What do they actually do?
Oh, they're incredibly versatile. Their most basic job is phagocytosis, literally eating microbes, cellular debris, dead cells. They're the cleanup crew. But they also initiate repair. They release signals that kickstart the process of scar formation, fibrosis, and they are major signalers themselves. They secrete mediators, powerful chemical messengers like cytokines, TNF, IL-1, chemokines to call in reinforcements, and other inflammatory molecules called eicosanoids.
Okay, so cleanup, repair signaling, and calling for backup. What else? There's a communication role too, right?
Yes, and this is absolutely critical for chronic inflammation. They perform immune communication. Macrophages chop up ingested microbes or materials and present little pieces, antigens, on their surface to T lymphocytes. This tells the T cells what the threat is. Crucially, they also listen to signals coming back from T cells. This sets up this constant dialogue, a feedback loop between macrophages and T cells.
And that feedback loop is where it gets really interesting and potentially problematic.
Exactly. Because they are doing all these things at once, destroying things, communicating with the adaptive immune system, and trying to initiate repairs, they become central to both fighting the battle and, unfortunately, causing a lot of the long-term tissue damage. They're destroyers, communicators, and builders all rolled into one complex cell.
Destroyer and builder? That seems contradictory. How does one cell manage those opposing roles?
That's where macrophage polarization comes in. They're not just one type of cell doing one thing. Their function can shift dramatically depending on the signals they receive from their environment. We typically talk about two main activation states, or poles. Classical M1 versus alternative M2 activation. Understanding this difference is key to understanding chronic disease.
Okay, let's break that down. M1, you called it the warrior. What turns on that pathway?
M1 activation is triggered by signals that basically scream danger, infection. Think microbial products like endotoxin binding to receptors like TLRs on the macrophage surface. But the really potent classic signal comes from T cells, specifically the cytokine IFN-LOG, interferon gamma.
So interferon gamma tells the macrophage, go into attack mode.
Pretty much, it ramps up their killing capacity.
And what do they actually do when they're M1 activated? What's their output?
They become killing machines. They start producing large amounts of highly reactive molecules like nitric oxide, NO, and reactive oxygen species. Plus, they unleash potent enzymes from their lysosomes, all designed to destroy ingested microbes. They also pump out pro-inflammatory cytokines like IL-1, IL-12, IL-23, which amplify the inflammation and call in more troops. So the primary role of M1 is host defense, killing pathogens, and promoting inflammation. Pure offense.
Got it. Now, M2, the healer, this sounds like the opposite. What activates this pathway?
Right. M2 activation is typically induced by cytokines other than interferon gamma. The key signals are usually IL-4 and IL-13. Interestingly, these are often produced by a different subset of T cells, the Th2 cells, which we'll get to.
So different signals, different job. What's the M2 output? Not weapons, presumably.
No, M2s are focused on calming things down and rebuilding. They produced anti-inflammatory cytokines like IL-10 and TGF-A, transforming growth factor beta. TGF is a major driver of fibrosis. They also produce growth factors that stimulate cell proliferation and angiogenesis, new blood vessel formation. So their main roles are to suppress inflammation, clean up debris, and promote tissue repair and fibrosis. There's a construction crew, but sometimes they overdo it with the concrete, the collagen.
If we could see this happening, how would an M1-dominated area look different from an M2-dominated one?
Visually, an M1 site might look more, well, messy and destructive. Lots of inflammation, cell debris, maybe evidence of active killing. An M2 site would likely show less overt inflammation, but much more evidence of rebuilding specifically. Dense deposits of collagen, that fibrous tissue. It would look more like scar tissue forming, potentially distorting the normal structure.
So is it like a switch? The body flips from M1 to M2, or is it more complicated?
It's definitely more complicated. I mean, the ideal sequence might be M1 first to clear the threat, then M2 to clean up and repair. But in chronic inflammation, you often find both M1 and M2 types present at the same time, reflecting that ongoing battle between injury and attempted repair. And importantly, these aren't necessarily fixed states. M1 and M2 represent the ends of a spectrum. Macrophages are highly plastic. They can shift their function along this spectrum depending on the local signals. And M1 might become more M2-like or vice versa. That plasticity is actually a hot area for research now.
Okay, so the macrophage is this incredibly versatile central player, but you mentioned they talk to T cells. Let's bring in the lymphocytes. Why are they so crucial for making inflammation chronic?
The lymphocytes, T cells, and B cells, they bring in the power of the adaptive immune system. Their involvement is what really locks in the persistence and often the severity of chronic inflammation. Why? Because they have memory.
Memory cells, meaning the body remembers the trigger.
Exactly. Once T and D cells have been activated by a specific antigen, they form long-lived memory cells. This means the body can mount a much faster and stronger response if it encounters that trigger again, even years later. This keeps the potential for inflammation constantly simmering.
Let's focus on the T cells, specifically the CD4 plus helper T cells. You said they act like generals, directing the battle.
That's a good analogy. CD4 plus T cells orchestrate the immune response by releasing different sets of cytokines, which then influence what other cells, like macrophages, do. We mainly talk about three key subsets.
Okay, lay them out for us.
First, the Th1 cells. These guys are the main producers of that key M1 activating cytokine, IFN, interferon gamma. So Th1 cells drive macrophages towards that aggressive microbe-killing M1 phenotype.
So Th1 equals M1 activation equals fight infection.
Right. Crucial for dealing with intracellular bacteria and viruses. But they're also heavily implicated when things go wrong in autoimmune diseases. Think multiple sclerosis, type 1 diabetes diseases, often driven by Th1 responses damaging tissues.
Okay, subset number 2.
Th2 cells. These produce a different set of cytokines, IL-4, IL-5, and IL-13. We just heard about IL-4 and IL-13. They push macrophages towards the M2 healer state. IL-5 is particularly important for recruiting and activating another cell type, eosinophils.
So Th2 equals M2 activation equals repair and allergies.
Yes, Th2 responses are classically associated with defense against parasitic worms, helminths, and are the main drivers of allergic inflammation. Think asthma, eczema.
Got it. And the third subset, you mentioned this one was maybe a bit newer on the scene.
Relatively speaking, yes. Th17 cells. They're defined by their production of IL-17 and related cytokines. IL-17 is a potent signal, especially for recruiting neutrophils, those acute inflammatory cells, and also monocytes, into the tissue.
So Th17 brings in the neutrophils even in a chronic setting.
It's exactly. Th17 responses seem important for defense against certain extracellular bacteria and fungi. But, like Th1 cells, they are also major players in several autoimmune diseases, like psoriasis, inflammatory bowel disease, Crohn's, and ankylosing spondylitis. The IL-17-driven neutrophil influx causes a lot of tissue damage in those conditions.
This interplay is getting complex. Macrophages activate T cells tell macrophages and others what to do. This sounds like a recipe for a cycle.
It is the recipe. This is the core engine, the
Yeah.
bidirectional feedback loop. It works like this. Macrophages gobble up an antigen, process it, and show it to T cells. They also release cytokines, like IL-12, which helps activate the T cells, specifically towards Th1.
Okay.
Then the activated T cells, say Th1 cells, release their own cytokines, like IFN phase. This IFN goes back and superactivates the macrophages, making them better killers and better antigen presenters. The T cells also release chemokines that call in more macrophages and more lymphocytes to the site.
So it just feeds itself. More macrophages activate more T cells, which activate more macrophages.
Precisely. It becomes a self-perpetuating cycle. Each cell type stimulates the other, amplifying the response and making it incredibly difficult to shut down. This persistent loop is arguably the hallmark of chronic cell-mediated inflammation.
And this is what leads to that long-term damage and maybe even those organized structures like granulomas.
Yes, absolutely. And we shouldn't forget the B cells in all this.
Right, the antibody makers.
Activated B cells mature into plasma cells, which are essentially antibody factories. In some really intense chronic inflammatory settings like the inflamed joint lining, synovium in rheumatoid arthritis, or a thyroid in Hashimoto's thyroiditis, you actually see lymphocytes, plasma cells, and macrophages clustering together.
Forming what look like mini lymph nodes.
Exactly. They organize into structures called tertiary lymphoid organs. It's like the immune system is setting up a local command center right there in the inflamed tissue, potentially generating and refining the immune attack on site, making it even more persistent.
Okay, beyond the big two macrophages and lymphocytes you mentioned, other cells get drawn into the chronic fray. Let's talk about eosinophils. Where do they fit in?
Eosinophils are quite specialized. You see them prominently in two main settings: immune reactions involving IgE antibodies, which is the hallmark of allergies, and in defense against parasitic infections, especially worms,
How do they get called in?
by specific chemokines, particularly one called eotaxin. Macrophages and Th2 lymphocytes can release eotaxin, specifically recruiting eosinophils to the site.
And what makes them dangerous? Or useful, I guess.
Their power lies in their granules. They contain a unique protein called major basic protein, MBP. MBP is highly toxic to parasites, which is good. But the downside is it's also toxic to our own cells, especially epithelial cells like those lining our airways or gut.
So in allergies like asthma, the eosinophils are actually damaging the airway lining.
Exactly. The MBP released by eosinophils contributes significantly to the epithelial damage, inflammation, and airway remodeling we see in chronic asthma and other allergic diseases. They're trying to help, but cause significant collateral damage.
Okay, who else is in the mix? Mast cells. I usually think of them in terms of like bee stings and sudden allergic reactions.
You're right. They are key players in immediate hypersensitivity anaphylaxis because they have IgE receptors on their surface. When an allergen binds, they rapidly release histamine and other mediators, causing those dramatic, acute symptoms. But they're also present in tissues chronically. They're widely distributed in connective tissue, and they don't just release histamine. They can secrete a whole plethora of cytokines and other mediators that influence the local inflammatory environment over the long term. Think of them as little cytokine depots scattered throughout the tissues, contributing to the chronic background noise.
Interesting. Now, what about neutrophils? We started by saying chronic inflammation is mononuclear cells, not neutrophils, but you're saying they can hang around.
They definitely can. While mononuclear cells define the chronic state, you often see persistent or recurring waves of neutrophils in many chronic inflammatory conditions. We sometimes call this acute on chronic inflammation.
Why would they still be there if the battle's been going on for months or years?
A couple of reasons. One, if there's a persistent high load of microbes that keep triggering an acute response, think of a chronic bone infection, osteomyelitis, where bacteria are constantly present. Two, the mediators released by the chronic inflammatory cells, particularly activated macrophages, and those Th17 cells we mentioned, can actively recruit neutrophils. IL-17 from Th17 cells is a powerful neutrophil chemoattractant.
So the chronic inflammation itself can keep calling in the acute responders.
Yes, and these persistent neutrophils contribute significantly to tissue damage because they release potent enzymes like proteases and elastase and reactive oxygen species. Think about lung damage in chronic bronchitis or COPD, exacerbated by smoking. Neutrophils play a big role there.
All right, we've mentioned them a few times. Sometimes this chronic process becomes incredibly organized, forming distinct structures. Let's talk about granulomatous inflammation.
Right. Granulomas are a very specific, distinct pattern of chronic inflammation. It's not just a random collection of cells, it's highly organized. The defining feature is a dense aggregation of activated macrophages, often with a surrounding collar of lymphocytes, especially T cells.
What's the point of building this structure? Why does the body do this?
It's essentially a cellular strategy to contain something the body finds really difficult, if not impossible, to get rid of. Think of it as building a wall around the offending agent.
Containing what, usually?
Typically, either persistent microbes that resist killing, like the tuberculosis bacillus, or large, inert foreign materials that can't be easily phagocytosed, like suture fragments or talc particles.
Let's break down the structure. You said activated macrophages are key. Do they look different in a granuloma?
They do. They transform into cells called epithelioid cells. They get larger, develop more cytoplasm that looks pink and granular under the microscope, and their cell boundaries become kind of indistinct, making them look a bit like epithelial cells squished together, hence the name.
Like paving stones forming a wall.
Exactly. And sometimes these epithelioid cells fuse together.
Ah, creating those giant cells.
Yes, forming multinucleated giant cells, often called Langen's giant cells in the context of infections like PB. These are huge cells, maybe 40, 50 micrometers across, containing many nuclei, often arranged in a ring or horseshoe shape at the edge of the cell. They represent a massive fusion of macrophages trying to deal with a persistent stimulus.
So you have this core of epithelioid cells and giant cells. What's around it?
Typically a surrounding collar of lymphocytes, mainly T cells, which are essential for maintaining the macrophage activation. And in older, more established granulomas, you often see a rim of fibroblasts and connective tissue starting to form. That's the body trying to permanently wall off the area with scar tissue.
Okay. Now, are all granulomas the same, or are there different types depending on the cause?
There are two main types based on the trigger. First, foreign body granulomas. These form in response to relatively inert foreign materials. Think talc powder, like from surgical gloves historically, suture material, maybe a wood splinter. The key here is that these materials are usually too large for one macrophage to eat, but they don't typically provoke a strong, specific T-cell immune response. They're non-immunogenic, so you get the macrophages and giant cells clustering around the material itself, which you can often see right in the center of the granuloma.
Makes sense. What's the other type, the one linked to infections?
That's the immune granuloma. This type is caused by agents that trigger a persistent T-cell-mediated immune response. The agent is difficult to eradicate, and the ongoing T-cell activation, especially Th1 cells producing IF-endo, is required to activate the macrophages and drive the granuloma formation. The absolute classic example is tuberculosis. But you also see immune granulomas in other infections like leprosy, some fungal infections, and even in some autoimmune-like conditions such as sarcoidosis or Crohn's disease.
With immune granulomas, particularly TB, we often hear about necrosis tissue death within the granuloma. What's caseous necrosis?
Right. In many immune granulomas, especially those caused by TB, the intense inflammation combined with low oxygen levels, hypoxia, and damage from free radicals in the center leads to a specific type of necrosis. Grossly, the dead tissue looks soft, white, and crumbly, kind of like cheese, hence caseous.
Cheesy death. Lovely.
Yeah. Microscopically, it's just amorphous, granular, pink debris. All the cell structures are obliterated. It represents the ground zero of the intense battle.
Is this necrosis always present in immune granulomas?
Not necessarily. While it's classic for TB, granulomas in other conditions like sarcoidosis, Crohn's disease, or foreign body reactions are often non-caseating, meaning they have the organized structure of epithelioid cells and lymphocytes, but they lack that central area of cheesy necrosis. Finding caseous necrosis points strongly towards TB, while its absence might suggest other causes.
So recognizing a granuloma, and whether it's caseating or not, is a huge diagnostic clue.
Absolutely critical. If a pathologist sees granulomas, especially case-eating ones, TB is immediately high on the list of possibilities, along with certain fungal infections. Other serious conditions like sarcoidosis or Crohn's are considered for non-case-eating granulomas. It really narrows down the potential diagnoses. And even when the granuloma eventually heals, the process often involves significant fibrosis, leaving behind a permanent scar that can impair organ function. Think of old calcified granulomas in the lungs from past TB infection. They represent permanently damaged lung tissue.
Okay, this detailed picture of the cells and their interactions is fascinating, but also a bit daunting. Let's shift to how this knowledge is actually being used. Where is the research heading in terms of treatment?
Yeah, this is where the detailed science really pays off. Understanding these cellular players and their signals opens up possibilities for much more targeted therapies, moving beyond just broadly suppressing inflammation.
We talked about M1 and M2 macrophages, the warrior and the healer.
Hmm.
You mentioned they're plastic. Can we actually manipulate that? Can we encourage macrophages to be less destructive or more reparative?
That's exactly where a lot of research is focused. While M1 and M2 are useful concepts for the poles of activation, we now understand it's a spectrum, and macrophages can shift along it. They can change their phenotype based on the signals they get. This plasticity is a huge therapeutic opportunity.
How so? Like if someone has rheumatoid arthritis, which involves a lot of destructive M1 activity.
Right. Could we develop drugs that specifically dampen those M1 polarizing signals? Or perhaps even push those macrophages towards a more M2-like anti-inflammatory resolving phenotype? That's one angle. The other angle is relevant for diseases dominated by excessive fibrosis, like idiopathic pulmonary fibrosis or liver cirrhosis, which are often driven by overactive M2 macrophages laying down too much collagen.
So there, you'd want to dampen the M2 activity. Or maybe make the fibrosis resolve.
Exactly. Researchers are looking for ways to selectively inhibit those profibrotic M2 pathways or even promote pathways that might help break down existing scar tissue. It's about modulating the balance between M1 and M2 activity, tailoring it to the specific disease context.
And what about targeting the T cell subsets? We now know Th1, Th2, Th17 drive different kinds of inflammation. Can we target them specifically?
Absolutely. This has been one of the biggest breakthroughs in recent years, moving away from broad immunosuppressants like steroids, which hit everything, towards highly specific biologics. For instance, we know Th17 cells drive inflammation in psoriasis, partly by producing IL-17, which recruits neutrophils. So drugs were developed that specifically block IL-17 or its receptor.
And do they work?
Remarkably well for many patients with psoriasis and related conditions like psoriatic arthritis or ankylosing spondylitis. It's a prime example of how understanding the specific cytokine driving a specific cellular pathway leads directly to effective targeted therapy. Similarly, there are therapies targeting IL-4 and IL-13, signaling for Th2-driven diseases like severe asthma or atopic dermatitis.
In targeting the communication loop itself, you mentioned macrophages secrete TNF, which activates other cells.
Yes. Anti-TNF therapies were among the first really successful biologics for chronic inflammatory diseases like rheumatoid arthritis and Crohn's disease. TNF is a key pro-inflammatory cytokine produced mainly by M1 macrophages. Blocking it disrupts that positive feedback loop between macrophages and other immune cells, significantly reducing inflammation and joint damage for many people. It proves that interfering with the cellular conversation can be highly effective.
Okay, let's try to wrap this up. To bring it all together for you, the listener, chronic inflammation isn't just an injury that won't heal. It's this incredibly dynamic, ongoing conflict.
Yeah, a complex conversation really between these versatile cells, the macrophages acting as fighters and cleaners, the lymphocytes as strategists calling the shots and remembering the enemy, and sometimes leading to these fortress-like granulomas.
And the key difference, the thing that makes chronic inflammation so different from a quick, acute response, seems to be the deep involvement of that adaptive immune system, the lymphocytes with their memory, and this dual nature of the macrophage.
Exactly. The macrophage is trying to defend M1 and trying to repair M2, but in the chronic setting, these processes get tangled up, they fuel each other, and the repair itself often becomes destructive through fibrosis.
Which leads us to a final thought. We spent a lot of time talking about how the healing process itself, the fibrosis, the scarring driven largely by M2 macrophages, causes so much irreversible organ damage in the long run.
It's the scar tissue that ultimately destroys lung function and pulmonary fibrosis, or liver function and cirrhosis.
So here's something to ponder. We put enormous effort into stopping the initial trigger, the infection, the autoimmune attack. But what if we also need to focus on stopping the healing from going wrong? Could future therapies target that destructive repair, the excessive fibrosis, perhaps by modulating M2 activity just as much as they target the initial inflammation?
It's a really interesting question. How do you promote beneficial repair without letting it run rampant and become destructive fibrosis? Managing that balance, learning how to guide the healing process itself, might be just as important as stopping the initial fight. That's definitely a major frontier in tackling these devastating chronic diseases.
Food for thought. Understanding this complex internal conflict is the first step. Thanks for joining us on the Deep Dive.